For this next video, we're going to be talking about dyspnea, or shortness of breath. Let's jump right into acute, potentially life-threatening condition associated with dyspnea, and this is anaphylaxis. So anaphylaxis is an acute, potentially life-threatening IgE-mediated allergic reaction that occurs in previously sensitized people when they're re-exposed to the sensitizing antigen. So some symptoms you'll see are stridor, dyspnea, wheezing, also hypotension, very common finding. The diagnosis here is going to be all clinically based. Treatment is usually with epinephrine. Bronchospasm and upper airway edema may require inhaled or injected beta agonists and sometimes endotracheal intubation. Finally, persistent hypotension requires IV fluids and sometimes vasopressors. When talking about the etiology of anaphylaxis, it's typically triggered by drugs such as beta-lactam antibiotics, sometimes insulin, other times streptokinase, and different allergen extracts. Another category of etiology would include foods, and these would most commonly include nuts, eggs, and seafood. Also, we have proteins such as the tetanus antitoxin. Also, blood transfusions could trigger an anaphylactic reaction. There's also animal venoms and latex as well. I want you guys to keep in mind that peanut and latex allergens may be airborne, and occasionally exercise or cold exposure could trigger or contribute to an anaphylactic reaction. Any history of atopy does not increase risk of anaphylaxis, but it does increase the risk of death when anaphylaxis occurs. In terms of the pathophysiology of anaphylaxis, this is an interaction of antigen with IgE on the basophils and mast cells. This triggers release of histamine, leukotrienes, and other mediators that cause diffuse smooth muscle contraction. This results in bronchoconstriction, vomiting, or diarrhea. Also vasodilation with plasma leakage, and this is generally resulting in urticaria or angioedema. Let's talk more about the symptoms and signs of anaphylaxis. So the symptoms of anaphylaxis typically begin within 15 minutes of exposure and involves the skin, the upper and or lower airways, cardiovascular system, or GI tract. One or more of these areas may be affected, and the symptoms do not necessarily progress from mild, like hives, to severe, such as airway obstruction or refractory shock, although each patient typically manifests the same reaction to subsequent exposures. Now, symptoms range from mild to severe and include flushing, pruritus, urticaria, sneezing, rhinorrhea, nausea, abdominal cramps, diarrhea, a sense of choking or dyspnea. Also, palpitations and dizziness could be a finding in anaphylaxis. Signs of anaphylaxis also could include low blood pressure, tachycardia, urticaria, angioedema, wheezing, stridor, cyanosis, and syncope. Shock can develop within minutes, and patients may have seizures, become unresponsive, and die. Cardiovascular collapse can occur without respiratory or other symptoms. Now, there are late phase reactions which may occur 4 to 8 hours after the exposure or later. Symptoms and signs are usually less severe than they were initially and may be limited to urticaria. However, they may be more severe or even fatal. Let's talk about status asthmaticus. So, status asthmaticus is considered a medical emergency. It's the extreme form of an asthma exacerbation that can result in hypoxemia, hypercarbia, and secondary respiratory failure. In practice, the role of the nurse practitioner is to prevent this from happening through patient compliance with their controller medications, such as steroid inhalers. Patient education plays a very major role in preventing recurrent attacks of status asthmaticus. On physical exam, these patients are usually tachypnic upon examination and, in the early stages of status asthmaticus, they may have significant wheezing. Initially, wheezing is heard only during expiration, but wheezing later occurs during expiration and inspiration. You'll notice the chest is hyperexpanded and accessory muscles, Particularly the sternocleidomastoid, scalene, and intercostal muscles are used. Later, as bronchoconstriction worsens, the wheezing may disappear, which may indicate severe airflow obstruction. Normally, the difference in systolic blood pressure between inspiration and expiration does not exceed 15 millimeters of mercury. In patients with severe asthma, a difference of greater than 25 millimeters of mercury usually indicates severe airway obstruction. If you ever find an inability to speak more than one or two words at a time, this can also be observed in the later stages of an acute asthma episode. The ventilation perfusion mismatch results in decreased oxygen saturation and also hypoxia. Vital signs may show tachycardia and also high blood pressure. The peak flow rate should be included in the vital signs in patients who are able to cooperate and who are able to tolerate the peak flow maneuver without significant distress. You may find the patient's level of consciousness may progress from lethargy to agitation, air hunger, and even syncope and seizures. If untreated, prolonged airway obstruction and marked increase in the work of breathing may eventually lead to bradycardia, hypoventilation, and even cardiorespiratory arrest. Now, we couldn't skip heart failure when talking about dyspnea. Let's talk about heart failure a little bit. I really just wanted to more so focus on your physical exam in terms of assessing dyspnea. So, general examination may detect signs of systemic or cardiac disorders that cause or aggravate heart failure. Some examples of this would be anemia, hyperthyroidism, alcoholism, hemochromatosis, atrial fibrillation with rapid rate, also mitral regurgitation. So, in left ventricle failure, tachycardia and tachypnea may occur. Patients with severe left ventricular failure may appear visibly dyspneic or cyanotic, hypotensive, and confused or agitated because of hypoxia and poor cerebral perfusion. Some of these less specific symptoms, such as confusion, are more common in the elderly. Central cyanosis reflects severe hypoxemia. Peripheral cyanosis of the lips, fingers, and toes reflects low blood flow with increased oxygen extraction. If vigorous massage improves nail bed color, cyanosis may only be peripheral. Increasing local blood flow does not improve color if cyanosis is truly central in nature. Cardiac findings in heart failure with reduced ejection fraction, or HFrEF, include a diffuse, sustained, and laterally displaced apical impulse. You'll have audible and occasional palpable third or S3 and fourth or S4 heart sounds, and an accentuated pulmonic component, or P2, of the second heart sound. These abnormal heart sounds can also occur in heart failure with preserved ejection fraction, or HFpEF. A pansystolic murmur of mitral regurgitation at the apex may occur in either HFrEF or HFpEF. Pulmonary findings include early inspiratory basilar crackles that do not clear with coughing, and if a pleural effusion is present, there'll be dullness to percussion and diminished breath sounds at the lung bases. Signs of right ventricular failure include non-tender peripheral pitting edema in the feet and ankles, an enlarged and sometimes pulsatile liver palpable below the right costal margin, abdominal swelling and ascites, and visible elevation of the jugular venous pressure, sometimes with large alpha or V waves that are visible when the patient is seated or standing. Large V waves in the jugular veins are usually indicative of significant tricuspid regurgitation, which is often present in right ventricular failure. A paradoxical increase in the jugular venous pressure during inspiration, also known as Kussmaul sign, is indicative of right-sided heart failure and can be seen in right ventricular failure, restrictive cardiomyopathy, constrictive pericarditis, and severe tricuspid regurgitation. In severe cases of heart failure, peripheral edema can extend to the thighs or even the sacrum, scrotum, lower abdominal wall, and occasionally even higher. Severe edema in multiple areas is termed anasarca. Edema may be asymptomatic if patients lie predominantly on one side. With hepatic congestion, the liver may be palpably enlarged or tender, and hepatojugular or abdominal jugular reflux may be detected. Precordial palpation may detect the left parasternal lift of right ventricular enlargement, and auscultation may detect the murmur of tricuspid regurgitation, or the right ventricular S3 along the left sternal border. Both findings are augmented upon inspiration. Finally, when talking about dyspnea, we need to discuss anemia. So, anemia is a decrease in the number of red blood cells, hematocrit, or hemoglobin content. In men, the anemia is where hemoglobin is less than 14. In women, hemoglobin is generally less than 12. For infants, normal values vary with age, necessitating the use of age-related tables. So, anemia is not a diagnosis. What it is a manifestation of an underlying disorder. So, even mild asymptomatic anemia should be investigated so that the primary problem can be diagnosed and treated. Anemia is usually suspected based on the history and physical exam. Common symptoms and signs of anemia include general fatigue, weakness, dyspnea, more so on exertion, and also pallor. The history and physical examination are followed by laboratory testing with a complete blood cell count and peripheral smear. The differential diagnosis can then be further refined based on the results of testing. In terms of physical examination, a complete physical examination is necessary in this case. Signs of anemia itself are neither sensitive nor specific. However, pallor is common with severe anemia. Signs of underlying disorders are often more diagnostically accurate than are signs of anemia. Heme positive stool identifies GI bleeding. Hemorrhagic shock may result from acute bleeding. Jaundice may suggest hemolysis. Splenomegaly may occur with hemolysis, hemoglobinopathy, connective tissue disease, myeloproliferative disorder, infection, or even cancer. Peripheral neuropathy suggests vitamin B12 deficiency. Abdominal distension in a patient with blunt trauma suggests acute hemorrhage. Petechiae develop in thrombocytopenia or in platelet dysfunction. Fever and heart murmurs suggest infective endocarditis, which is a possible cause of hemolysis. Finally, rarely, high output heart failure develops as a compensatory response to anemia induced tissue hypoxia.